Welcome to HealthTalk TV. The treatment of chronic lymphocytic leukemia, also known as CLL, is changing rapidly. For many patients, we are now moving away from chemotherapy towards targeted therapies, and increasingly towards fixed duration treatment. But with several effective options available, a key question remains: how do we choose the right treatment for the right patient? To help us navigate this evolving landscape, I'm joined by Dr. Eugen Tausch, one of the leading international experts in CLL. Dr. Tausch, thank you very much for joining us.
Thank you very much, Lars. I'm happy to contribute and I'm looking forward to talk to you about CLL.
Thank you so much. So, first of all, Dr. Tausch, just to start, what is CLL and what defines this type of hematological cancer?
Yes, so chronic lymphocytic leukemia is a type of leukemia. It's the most frequent leukemia in the Western world. And although it is the most frequent leukemia, it's still quite rare compared to lung cancer or breast cancer, for example. And it's a leukemia, and at the same time, it's an indolent lymphoma, which means that it can induce lymphocytosis, but also lymphadenopathy, so big lymph nodes. And the disease, the course of the disease is very heterogeneous. There are some patients who will never receive any type of therapy and have a very good quality of life without having any without being affected by the disease itself, while others will need several courses of treatment and will really suffer from the disease. So it's a very heterogeneous and very interesting disease.
Thank you so much for the nice introduction, Dr. Tausch. Now, let's start with the big picture here. The ever-evolving first-line landscape in the treatment of CLL. As you know, over the past decade, treatment of CLL has changed dramatically with the introduction of targeted therapies. How would you describe the current first-line treatment landscape in CLL today?
Yeah, I think it was really a revolution that we had in the treatment of CLL, because a little bit more than 10 years ago, we treated patients typically with chemoimmunotherapy. So they received chemotherapy a number of cycles and indeed suffered from the side effects from a chemotherapy. And this totally changed, because in the first line, chemotherapy is actually not a typical valid option and will be only used for a very small part of specific patients, because the new compounds are so efficacious and also so well tolerated, and the new compounds are mainly one thing BTK inhibitors, the second BCL2 inhibitors, and still CD20 antibodies play an important role.
Yeah. And now that we have all these types of new treatment options, one key question remains then: how do we choose the right strategy for the right patients? So when you, as a doctor and professor, you see a newly diagnosed patient who requires treatment, you already know that today we have several effective options available. Can you talk us through about what are the most important factors that guide your choice of therapy in the first-line setting today?
Yes. So with all these new compounds, we can say we have two different treatment strategies. One is a continuous treatment with a single BTK inhibitor, which is given over years until the patients progress or the treatment is not tolerated anymore. Then we have to switch or change the treatment regimen. And the other one is to combine two compounds together and then have a time-limited therapy for a year or 15 months. And so then we can at that point stop the treatment and have a time after stop of therapy, which can be 2, 3, 5, or even 10 years without any need for therapy and without a visible disease or detectable disease. So these are the two main strategies that we have. And of course, we can say what is the better one for this patient and for the other. There are many different factors that should be considered in that point. One factor which is very important and which is stated in many of the guidelines is the risk strategy for the CLL. So to see whether this is a low-risk CLL according to the genetics, the IGHV status, the TP53 and 17p deletion status, or if this is a high-risk CLL who all have this deletion 17p or p53 mutation. And this has a strong impact of what to expect from the disease itself. Those patients with a very indolent low-risk disease, if they get a combination therapy for 1 year, they will have 7, 8, possibly 10 or more years of a treatment-free interval before the relapse occurs. So this is very, very efficacious treatment of this patient for a year, and then having this long time afterwards where the patient do not suffer either side effects from the treatment nor the disease itself. While for the high-risk patients, this is different. So we still have 1 year or 1.5 years of therapy, but then the disease comes back in 2, 3, or 4 years. So there we have to take into account that possibly the side effects of such a combination can be stronger, and the benefit of a long treatment-free interval afterwards is shorter. So that means that indeed the genetic risk factors is something very important to consider in the treatment choice, and for this high-risk patient, possibly a single-agent continuous treatment would be the better treatment. But there are other factors as well. There are co-occurrent diseases that the patient have. For example, renal impairment, so renal dysfunction. So this could be a problem when we use venetoclax during the ramp-up. On the other hand, we could have problems with patients who are taking anticoagulation treatment, for example, or who have a very strong risk for cardiac disease. For these patients, ibrutinib or other BTK inhibitors would be the best choice. And there is, besides side effects and co-occurrent medication that the patient receive, I think there is also sometimes that patients prefer the strategy to have a continuous treatment with a single agent and come every 3 months to a doctor to control, to get a blood draw or things like that. And others who really want to have a very condensed treatment, come more frequent to the doctor, but only for 1 year, and then remain. And it can be circumstances from if the patient are still working, or if they're retired, for example, if they have the possibility to swallow capsules, if they have problems to swallow capsules, if they are afraid of infusions, all things like that. So today we have very, very effective treatment options, so we can choose very nicely, and we can consider much more factors for this patient to choose an optimal treatment.
So, since you have all of these choices now, is the patient involvement in the treatment plan even more important than for maybe other diseases?
Yes, I fully agree to that point, because we have very equally effective treatments at first line. We have different options, and therefore it is really important to sit down and to talk with the patient about each of these options, with the benefits and the risk for each of this option. And typically in the talk with the patient, there will be a concept that turns out to be optimal, okay? And as I said, there are different factors to consider. One can be weighted a little bit more than the other, but finally the patient has to take the choice together with the medical doctor, who is actually giving an advice or a guidance for the patient with all this knowledge.
And what is your experience? Are more patients choosing the long-term or the short-term treatment options?
Yes. So many patients choose a short-term treatment due to the fact that they are typically afraid of side effects that can, in a continuous treatment, also occur in the 3rd or 4th or 5th year of therapy. Still, new side effects can occur at that time. So many patients choose a combination treatment as a first-line treatment, and then to just stop it and have a long treatment-free interval afterwards.
So you were already in on this subject. What types of treatments do you have now? And some important keywords here are the BTK inhibitors and the BCL2-based regimens. So today clinicians can choose between these two, the BTK inhibitor-based therapy and venetoclax-based combinations. So how do you currently view the role of BTK inhibitors compared with the venetoclax-based regimens in the first-line setting for CLL?
Yes, even more, Lars. We have in many countries even the option to have a combination of BTK and BCL2 inhibitors. So I think the major options that we have in the first line is one, a continuous treatment with the BTKI, which I already mentioned. And typically here we would choose the second generation BTKI, zanubrutinib or acalabrutinib, and prefer them not to take ibrutinib. Then the second option is that we have is a time-limited treatment with venetoclax, the BCL2 inhibitor, in combination with obinutuzumab as a CD20 antibody, which means oral plus IV treatment combination for 12 months and then stop of treatment and have a very deep response typically, which we can expect from this combination. And the third option is indeed combining the two oral drugs, BTK inhibitor and BCL2 inhibitor, and giving them for a term of 14 or 15 months. This is the combination acalabrutinib plus venetoclax or ibrutinib plus venetoclax. And with acalabrutinib venetoclax we have even a triplet option, adding obinutuzumab in addition, but I'm still looking for those patients because actually I don't know if this is really necessary to have a triple combination. So we can talk about that, but I will mainly focus on the double combinations for time-limited therapy. And I think we have now really good data to say that these time-limited therapies are also very, very effective options, and possibly even comparable options with a little bit deeper responses in the venetoclax CD20 antibody combination. So the venetoclax obinutuzumab combination shows the highest undetectable MRD rates, which means actually you cannot find in many of these patients after the treatment any type of CLL cells, even if you look with a very sensitive method. For ibrutinib venetoclax, this is achieved in a lower amount of patient, but it's still achieved. And the progression-free survival, so the survival where the patient where we do not detect any disease, is very long for both of these type of time-limited therapies. So this is why they are actually preferable for all patients that are not high-risk patients, and as I said, considering other factors as well. Why the continuous treatment is the option that we typically choose for patients with 17p deletion and or TP53 mutation, so the very high-risk patients, because for them the treatment-free interval after a time-limited therapy is very short, we would expect, and therefore there are also some signs of shorter overall survival even in one of the trials, the CLL14 trial. So we are a little bit aware of giving this high-risk patients with deletion 17p a time-limited venetoclax obinutuzumab treatment, for example.
So, seeing as we already talked about what type of role now the patients are having with these new treatments, one keyword you mentioned now in the last sentence was clinical trials. There are a lot of clinical trial data now that are shaping the new practice for how we are treating CLL. A number of important clinical trials have recently reported results that may influence the treatment strategies for CLL. So, Dr. Tausch, which recent studies or clinical trial results do you believe have the greatest impact now on how we treat CLL today?
Yes, thank you. This is a very good question, actually. We had for many years the point that we always had trials of these new compounds or new compound combinations against chemotherapy, which is typical because chemotherapy was 10 years or longer ago the standard. But what we could not do is to really compare different treatment strategies, modern treatment strategies against each other, because they were all tested in clinical trials against chemo separately. So therefore, for me, one of the most important trials now is the CLL17 trial from the German CLL study group, which was shown on the ASH last year, in December last year, and it's also published. And this trial is the first trial that really compared continuous BTKI treatment with the ibrutinib versus the oral combination, ibrutinib plus venetoclax, time limited, versus the combination of IV plus oral, which means venetoclax plus CD20 antibody obinutuzumab, and compared if these three different treatment strategies are similar effective and are all similar tolerable, so have the same tolerability. And what is shown after at least the 3 years of follow-up, that the time-limited combinations in the full set of patients are comparably effective as the continuous monotherapy, but for some patients produce a little bit lower side effects, for others more. So we had more infections, for example, with the CD20 antibody plus venetoclax combinations, but less cardiac toxicity. For the continuous ibrutinib treatment, we had, so the continuous BTKI treatment, we had a little bit more cardiac toxicity, which means also hypertension, for example, but less impact on the infection rates. So these were the differences that we mainly found out, and I think this is one of the trials that give us a lot of data how to choose the optimal treatment for our first-line patients.
So, based on your experience, how do these findings from the study reflect on the clinical practice today?
Yes, I think they underlined the current guidelines, because the current guidelines, as I said, were based on cross-trial comparisons, and we were always unsafe if this is really true or if we're doing it correctly. But I think the CLL 17 trial really underlined many of the things that we expected and put it really into on a solid basis in regards to data. And I think this treatment, this study, again underlines the effectiveness and the usefulness of the combination of the oral combinations. Here's the I plus V treatment, which was also very good in this trial, and also that the selection of time-limited combinations for the majority of patients is possibly superior to the continuous treatment in regards to a long-term strategy.
So something you touched upon earlier in the interview was how a lot of patients can go several years without having any relapse, but eventually a lot of the patients will relapse or develop intolerance to the treatment that they're on. How do you currently think about treatment sequencing in CLL when patients relapse or require later lines in therapy?
Yeah, thanks. This is, again, there are different things that we need to consider. One thing is, again, favoring the time-limited combinations. This is the acquisition of resistance mutations. The patients can get resistance mutations with a continuous BTKI treatment. They can acquire BTK mutations, and this will then induce a resistance to the first and second generation inhibitors. So when you have a ibrutinib treatment continuous and you have a C481S mutation as a resistance mutation, you will not be able to have a zanubrutinib or acalabrutinib treatment in the next line. This is different with treatment combinations in the first line, because when patients relapse after such a combination, we can only see in very, very rare cases, and I'm talking about lower than 1% of patients, where we have an acquisition of the mutation. So in theory, we could do the same treatment once again, or a very similar time-limited treatment once again. So this is one aspect, is the generation of resistance. The other is, of course, the tolerability of the first-line therapy in regards to, are we going to do this once again? Do we try to repeat that because it will safety tolerable or not? And I think the third is the time of response to the first treatment. If you have a time-limited combination and patients respond for 7 or 8 years, then you should for sure do again a time-limited therapy combination in the second line. So it could be rituximab venetoclax, for example, as a combination which is given for 2 years, so 6 cycles of rituximab plus venetoclax, and then additional 1.5 years of venetoclax alone. If you have only a response to this first-line therapy of only 1 year or 2 years, then you should rather consider a switch to a BTKI continuous treatment, and then also think of further treatment strategies next. So I think it strongly depends on how long the response was to say we can do this once again or not. And about a threshold for repeating or switching would be for me 3 to 4 years. So everything above I would repeat, and everything below I would possibly switch.
You mentioned again BTK inhibitors here. They're a very important part now of the CLL treatment regimen. And we are now seeing the emergence of the next generation of BTK inhibitors, the so-called non-covalent BTK inhibitors, such as pirtobrutinib, which may possibly overcome the resistance to earlier BTK inhibitors. At the same time, we see studies such as Bruin CLL 313 trials that are exploring their potential role even earlier lines in the treatment of CLL. So, how do you see the role of these next generation BTK inhibitors evolving in the treatment of CLL?
Non-covalent BTK inhibitors are very, very important. This is a very important drug, as we know that there are trials where these treatments are very efficacious in patients who had several rounds of different therapies and do not respond to the covalent BTKIs anymore. And I think therefore this is a very important drug, as we have this is kind of an additional line of therapy that we can give patients after failure of time-limited combinations and also after covalent BTKI inhibitors. However, there are trials now that are testing pirtobrutinib in the first line, even in untreated patients, and we have seen that there is very good data also on this first-line usage for this treatment. It's possible that this will also result in an approval, so that we can in the near future use these non-covalent inhibitors as a continuous treatment in first-line therapy. And of course, this will be a valid option. On the other hand, we have to say that we have very, very solid and good data using this non-covalent inhibitors in patients who failed the covalent inhibitor treatment, so adding a next line of therapy. But we do not have much data the other way around, and I'm a little bit skeptical if that works, which means that possibly we will, when we're using this line of therapy as a first line, that possibly we will not have the option to have afterwards covalent BTKI inhibitors and lose a line of therapy. But this is something that I'm saying from my gut feeling, and there is not much data supporting all this sequencing when considering non-covalent inhibitors. As a additional type of treatment, this is very, very good therapy.
So what you're saying is that you're afraid to start too early with these new types of treatments. So in worst case, you miss the next step.
In worst case, you will lose the step to switch to a covalent inhibitor again, because possibly it will not work. Yes, you're totally right. This is what I'm saying.
So, like a clear example here, pirtobrutinib, as we mentioned. Do you think a drug like that eventually could move earlier into treatment algorithm, or is it the concerns that you're having regarding this also?
So I think the study data will result finally in an approval in the first line, but we should think about which patient to put on that, and I would like to see more data on the failure of pirtobrutinib in first line and what happens next to these patients, how good they respond, for example, to a oral combination or to a venetoclax-rituximab combination afterwards. So this data is missing, as it is always when you have a new approval. The follow-up data is yet missing.
Very good. So, Dr. Tausch, we are nearing the end of the TV episode here about CLL treatment, but finally, I guess we have to look a bit ahead now, seeing to the future. So, what developments in CLL research and treatment are you most excited about in the coming years?
I think I'm most excited about the point that actually a couple of years ago we said this is kind of a revolution of the treatment of CLL, and we were all afraid that with introduction of covalent BTKI and BCL2 inhibitors, the big steps are done and we will not see any of those anymore, but we do see them, and this is the good thing. We have, as you said, non-covalent inhibitors that are reaching now even possibly in near future the first-line treatment, but we have also a new type of compound, which is the BTK degrader. There are different companies who are developing BTK degraders, which goes ahead of just inhibiting them. They will induce a degradation of the whole molecule of BTK, which is possibly even more efficacious in blocking this type of signaling pathway. And also other steps are important. I think bispecifics, which are now more used in the aggressive lymphoma, DLBCL, etc., are coming into CLL as well. And I think it is important to also have drugs that do not go directly into this target BCL2 and BTKI, because we could expect that patients who are pre-treated with many lines of therapy will at one point not respond because they have signals that are going through other pathways, and for them it would be even more important to have also drugs in CLL approved that are, for example, binding the surface like bispecific antibodies do. And of course, there is an approval of CAR T-cell therapy in the US, and while the data of the typical used CAR T-cells are, let's say, not as promising as they are for other types of lymphoma, I think there is again room for improvement, and we will possibly see better data with combination therapies of CAR T plus specific compounds in the near future.
Dr. Tausch, thank you so much for sharing your insights with us today. This has been a very valuable discussion. As we can hear, CLL is clearly a field that continues to evolve rapidly with new treatment strategies and emerging data that will likely shape clinical practice in the years to come. I want to thank you, Dr. Tausch, so much for joining us here today, and I want to thank you, our viewers, for watching HealthTalk TV on CLL, and we will see you next time.